This topic is myocardial infarction, or MI. Myocardial infarction occurs when an unstable plaque ruptures within a coronary artery. This results in a thrombus that occludes the coronary artery that leads to ischemia and eventually cardiac cell death. The risk factors for MI are the same risk factors for coronary artery disease. These are going to be anything that raise your blood pressure or hypertension, as well as any conditions that raise your lipid levels in the blood or cause hyperlipidemia. Things like smoking or high levels of stress or even recreational drug use can cause hypertension, while a sedentary lifestyle and obesity can cause hyperlipidemia. Additionally, clients with a family history of MI are at risk for an MI themselves. The chief complaint of most clients with an MI is going to be chest pain. Now, this chest pain can look and feel different for different clients, but it's often going to be described as a heavy pressure or like someone is squeezing or tightening onto their chest. As the blockage continues to worsen blood flow and impede it further, pain can radiate to the neck, to the jaw, the back, and oftentimes down the left arm. This pain can occur without a precipitating event, and clients often report feeling this in the morning first upon waking. Unlike angina, this pain is going to be unrelieved by rest, position changes, and even nitroglycerin. The pain is also going to last 30 minutes or longer. Clients will also report feelings of impending doom. They may even say something like, "I feel like I'm going to die." They're going to be very anxious. As the heart's struggling to pump, the heart rate's going to increase and feelings of anxiety are going to increase too. As the heart struggles to pump and perfuse the organs in the extremities, clients are going to become weak and fatigued. Clients may also report indigestion or epigastric pain and sometimes think they're just having really bad reflux. It's also important to note that not every client is going to present with typical symptoms. Atypical symptoms are common in women, older adults, and clients with diabetes, especially those with peripheral neuropathy. These are going to be associated symptoms, but maybe not ischemic chest pain. These clients may just report being dizzy, fatigued, having a headache. A lot of them are going to report GI symptoms such as nausea, vomiting, or even just a really bad stomach ache. Clients with MI are going to have ECG changes. They're going to have changes within the ST segment, and this can either be a depression or an elevation. As you can see in the graphic here, a non-ST elevated myocardial infarction, or an NSTEMI, is going to have ST depression. That thrombus is only partially occluding the coronary artery. Blood flow is reduced, but there's still some blood flow happening. On the other hand, we have a STEMI, or an ST segment elevated myocardial infarction. This results when a thrombus completely occludes the coronary artery and there is no blood flow getting through. A STEMI is life-threatening and considered one of the highest medical emergencies. We have to get perfusion restored as soon as we can to the client's body. In addition to ECG changes, clients are also going to have elevated cardiac enzymes in their blood. A lot of these enzymes and proteins live within the heart muscle normally, but when heart muscle begins to die or is not receiving enough blood, the body releases them into the bloodstream. Because these have to be released into the bloodstream, they're not going to be immediately detectable in lab results. You're not going to see an increase in many of these lab values until about 4 to 6 hours after the client has an MI, and they're going to continue to rise until at least 24 hours after the MI. Whether the client's having an NSTEMI or a STEMI, early reperfusion is critical for preventing life-threatening complications. We need to restore blood flow as soon as possible to help reduce the amount of cardiac tissue that becomes dead and necrosed. Remember, cardiac muscle is not going to regenerate, so if the muscle dies, the muscle dies. We need to preserve as much as we can and prevent muscle death. Now, for clients having an MI, there's some different medications we can administer. Medications such as aspirin, ticagrelor, or clopidogrel are going to inhibit platelet aggregation. If there's already a thrombus in the artery, we don't want it to get any bigger, so we're going to try to prevent more platelets from attaching to it and growing. We also can administer nitrates to help vasodilate the vessels, reduce blood pressure, and increase the amount of blood flowing over the thrombus. Morphine's going to reduce preload and also just going to help the client rest and be a little less anxious. We're going to give oxygen if the client has a low oxygen saturation or if they're having visible signs of difficulty breathing, such as dyspnea. We're also going to administer beta blockers like metoprolol to help decrease the blood pressure in the heart rate and decrease the workload of the heart. Now, it's important to note that in some of these clients, they're going to have a decreased pulse and blood pressure. If they're already decreased, we don't want to decrease them more with the beta blocker, so we need to make sure we understand the healthcare provider's order and administer drugs appropriately. Medications such as continuous IV heparin may also be prescribed. If we can thin the blood, we can help the blood slide past a thrombus and increase the blood flow. Additionally, we can administer statin therapy because this is going to lower the bad cholesterol and raise the good. This one's going to help us more in the long term, but it's important to start administering it as soon as we can. We also need to prepare the clients for percutaneous coronary intervention, or PCI. Going into the cardiac cath lab will allow the healthcare provider to visualize any blockages the client has, as well as stent, balloon, or both to them. If you're in a rural area or you don't have immediate access to a cath lab, something like thrombolytic therapy may be beneficial to your client. A medication such as TPA can break up our bus clots, but not every client's going to be eligible. We need to screen clients for conditions such as bleeding disorders or history of hemorrhagic stroke, because these would be contraindications to thrombolytic therapy. Finally, we need to initiate continuous cardiac monitoring. Clients who have recently had an MI or are actively having an MI are at risk for cardiac dysrhythmias, potentially lethal cardiac dysrhythmias. PCI is going to be our preferred first-line treatment. When we think about reperfusion therapy, we need to think about retrieving the thrombus, because if we leave all or part of it, it can travel to the lungs and cause a pulmonary embolism, or even travel to the brain and cause ischemic stroke. Angioplasty needs to be completed, where we get rid of the blockage as much as we can with either a stent, balloon, or both. We want to perform PCI as soon as possible for clients with an MI, especially those with a STEMI. This needs to be performed within 90 minutes of first medical contact. So if the client walks into the ED, it needs to be 90 minutes from there, or if the client is out in the community and calls EMS, it needs to be 90 minutes from that time. Now, sometimes clients have blockages that are too dense or too large to be ballooned or stented. In this case, they're going to need coronary artery bypass grafting or CABG surgery. In CABG, a vein is taken typically from the leg, and rather than going through the blockage, we go around it or bypass it. The graft is sewn in above and below the blockage to restore blood flow. Now, CABG is an open heart surgery and a lot more invasive than PCI, so these clients are going to have different teaching post-operatively, as well as different monitoring and different nursing interventions that need to be completed after the procedure. These clients are going to require advanced hemodynamic monitoring for things such as central venous pressure, or CVP, as well as pulmonary artery pressure monitoring, or PA catheter. These clients may also need blood products administered, as well as electrolyte repletion and continuous cardiac monitoring, as well as frequent serum electrolyte monitoring. These clients also need to have their temperature monitored continuously, as well as hourly logging of intake and output. Because clients with an MI have weakened or damaged cardiac tissue, they're at a higher risk for dysrhythmias, and some of these can be lethal or life-threatening. If the heart's still pumping, but there is a blockage in place or a dead area of tissue, the blood is not all going to be able to be pumped out, and this can result in heart failure. We're going to have swelling or edema and fluid buildup in the lungs. Now remember, when clients are having an MI, they are having an occluded artery. The heart is going to pump and work really hard to try to go around the blockage and still have adequate blood flow. But it's just not going to be able to because the blockage is there. Sometimes the heart is going to work and work and work and suddenly decide that it just can't work anymore. If the heart suddenly drops off in its output and its effectiveness, we're going to have cardiogenic shock. Like I said, when cardiac tissue has damage or death, it's not going to regenerate. Once there's an area of necrosed or dead tissue, the body's going to recognize that as a foreign object and it's going to try to remove it or get rid of it. This is where pericarditis can occur. We're going to have lots of inflammation and even lots of fluid coming in around that dead tissue. This is going to result in muffled heart tones and can even progress to other issues. Remember also that the heart is an electrical conduction system. If we have dead or necrosed tissue, the electrical signals are just not going to be able to get where they need to go. They're going to be blocked and stopped by that dead tissue. This is where things like mitral valve insufficiency can occur. Now, if the electrical signals cannot get to the chordae tendineae that control the mitral valve to tell it to do its thing, Or if the chordae tendineae themselves are damaged from the MI, we're going to have blood back up into the chambers of the heart because the mitral valve is not opening and closing properly or allowing the blood to flow in and out as it should. Now, if we've got enough blood going back to the heart from the body and the mitral valve is causing blood to go back into the heart, we're going to have a backup of blood. Eventually, there may simply be too much blood sitting in the ventricles that can't get out, and this can result in ventricular rupture. If clients are having an MI and awaiting PCI, we need to make sure we keep them on bed rest. We need to reduce the amount of exertion they have as much as possible to help that heart rest as much as we can. We also need to place them in an upright position such as semi-Fowler to help reduce the workload on the heart. For clients who have CABG surgery, bed rest will be indicated at first, but pretty quickly clients need to get upright and mobile. The sooner we get them moving, the sooner we can get them discharged and go home, and the better their outcomes are going to be. For all clients who have had an MI, there are certain things we need to monitor. We need to be listening to heart tones, especially listening for the presence of an S3 or gallop, because these are going to indicate heart failure. If clients have pulmonary edema, we're going to hear crackles when we listen to their lungs, and they're going to have an increased respiratory rate and effort. They're probably going to have a cough that sounds like there's something coming up, but there may not actually be anything coming up with that cough. Like I mentioned earlier, these clients are at a huge risk for cardiac dysrhythmias, so we need to monitor them with continuous cardiac monitoring or telemetry. Lastly, we need to monitor the serum cardiac enzyme levels over time or trend them. We need to make sure that once these levels hit a peak, that they don't continue to rise, or that after a couple days they don't start to rise again, because that is going to indicate reinfarction. Finally, for all clients who've had an MI, we need to assess distal peripheral pulses as well as skin temperature. We need to make sure that blood flow is still getting to the extremities. This is going to be especially important for clients who have had a cardiac catheterization or they've undergone PCI through the femoral or radial entry. We've entered in through an artery, so we need to make sure that that artery is sealed back up, stayed sealed, and that blood flow is happening as normal. When we discharge a client who has had an MI, teaching is super important. Firstly, we want to teach them to continue their cardiac rehabilitation as well as their physical rehabilitation. Cardiac rehab is often completed in a program where clients have monitored exercise. These clients are going to wear the continuous cardiac monitor and complete low to moderate aerobic exercise. They also may complete this at home, or they may do both. Now, depending on the procedure the client has, they may need to wait a little to start their cardiac rehabilitation. Oftentimes, clients who have had CABG are going to need to wait a little longer than those who have had a stent or angioplasty. This time frame will be up to the client's healthcare provider. Clients may feel uncomfortable bringing it up, but clients need to understand the importance of abstaining from sexual activity until cleared by their healthcare provider. This is going to put work and strain on the heart, just like any other exerting activity, and clients need to wait until it is safe for them to do so. Additionally, if clients take medications such as sildenafil, they need to speak with their healthcare provider before resuming that medication because of the vasodilation it can cause. Clients also need to be taught to modify their risk factors for cardiac disease. If clients smoke, cessation should be pushed. Clients need to understand that smoking is going to raise the blood pressure and in turn degrade vascular integrity. Clients also need to be taught about nutrition choices. Diets such as the DASH diet are going to be low in sodium and saturated fats and high in things like potassium and fiber. Making dietary modifications is going to help lower blood pressure as well as increase the good cholesterol, the HDL, and decrease the bad cholesterol, the LDL. It's also going to reduce the triglyceride levels. All of these things together are going to help prevent further plaques from forming in the coronary arteries. Clients also need to be taught about the importance of adhering to their medication regimen. Clients need to take medications as prescribed in terms of dosage and timing. We also need to teach clients how to check things like their blood pressure, their pulse, and their weight. Medications such as beta blockers are going to be dependent upon the client's systolic blood pressure or their heart rate. The healthcare provider needs to be able to see over time if blood pressure control is adequate, as well as what the client's weight is. If the client begins retaining fluid, this could be an early sign of heart failure, and we need to intervene quickly to preserve heart function. Clients are going to have a lot of follow-up appointments to attend, especially if they had a more invasive procedure such as CABG. They need to understand the importance of attending all these follow-up appointments and why they have them in the first place. If a client's in a cardiac rehabilitation program, they may need to go multiple times per week for many months. We need to explain to them why it's important to go and why it's important to go to this particular program rather than just completing something on their own. Finally, clients need to monitor and report recurrent symptoms. If clients begin experiencing symptoms again, such as the chest pain that they had before, it could be a sign of reinfarction. If a client is having signs and symptoms of repeat MI, they need to go immediately to the emergency department or call EMS because another MI could be happening.